Welcome to everybody to Bainbridge Island Senior Community Center, Something to Talk About. We do this every weekday, almost every weekday at 11:30. If you are not currently a member of the Senior Center, I invite you to consider joining. It's just $20 a year, and you'll be funding some great outreach like this, in addition to a lot of other fun programs and activities that you'll learn about as soon as you become a member. Today, I am very happy to be welcoming Dr. Michael Soman, a physician. Is that how I pronounce your name, Michael? Soman?
Soman. It will
Soman.
Like Roman.
Roman Soman. Michael Soman is a physician, or has been a physician on Bainbridge Island for decades. He took care of many seniors, some of whom I believe might be on this call. After some time, he had growing management positions, culminating in being president of the Group Health Physicians Group, 1,200 clinicians in the state. He retired from that job in mid-2014. Michael has been a BI resident since 1987, and he has a great interest in the history of U.S. medicine. And I asked him if he could come and talk to us because we're all recognizing once again the upsets in our medical system based on the latest bit of news, which is that apparently Swedish is going to be closing its Bainbridge offices, which is just the latest in a lot of turns and twitches. And when I talked to Michael, he said, well, that's part of a greater issue, which I would love to talk about. So we would love to have you talk to us about it. Thank you for coming.
Yeah, thank you for asking me. You hear me all right, folks?
Yeah.
Okay. First of all, it's a pleasure to speak with you. I did take care of many of you because I practiced for a long time on this island. I completed my residency in family medicine in 1982. And like most recent trainees, I was in love with the diagnosis and treatment and prevention for whatever person was right in front of me. That's how we were trained in those days. I then studied public health for a couple of years at University of Washington, and that gave me a broader view of healthcare beyond the patient right in front of me, although that always remained critically important. I practiced in Burien, south of Seattle, for a few years, and then for a couple of decades on both Bainbridge and Paulsbo, where I founded both of those group health clinics. And then I turned it further into leadership. I kept practicing half-time, but ran primary care for the whole state for group health. And then I left practice entirely and ran the multi-specialty statewide group practice, caring for about 500,000 patients. And I did that until retiring in 2014. But for the last 6 years prior to retiring, I also became the president of Group Health Physicians, which had about 1,200 clinical people, the largest medical group in the state. It was really important and really gratifying work. But as my 4- and 7-year-old grandsons would say, it was also kind of yucky because of the politics. What a surprise. Over the years, I really became fascinated by the history, politics, and finances of the U.S. healthcare system. And when you're a medical director, you always get asked to give talks on the future of healthcare. And I'd always say, no, I want to talk about how we got here. Because if we don't first talk about that, we won't know where to go. Can I have the first slide, Reed? Our healthcare system is incredibly complex. I think we have a slide of a Rube Goldberg rendering. You can see this gentleman's trying to get toothpaste on a toothbrush, and he has this incredibly cumbersome machinery. And you could argue that that is the United States healthcare system in a nutshell, except that instead of putting toothpaste on a toothbrush, there's a different purpose of this system, which I ask you all to imagine what you think that might be, and I'll give you my sense in a couple of minutes what I think it is. If we can have the next slide, there have been many efforts to reform our healthcare system spanning over 100 years now. And you can see not everything, but the major ones on this slide, starting with Teddy Roosevelt. But really, when things started to codify were right during and after World War II, 1940 to 45. And what happened that was really important and undervalued by Americans was that at that time there was a wage freeze and employers couldn't offer more money to workers. Some of you may remember that. So employers came up with an ingenious idea, which is, let's just give people free health care. And that birthed probably the most unusual thing about the U.S. healthcare system. If you ask a lot of people, some will say, well, it's that not everybody's covered. Some will say it's that it's not that good. But really the most unique thing, there is nowhere else in the world where the employer is between the patient and the clinical team. And that was really an accident of history. And it created one of the major differences in our system. Also, that free healthcare, not free. Lots of economists have looked at that and said, well, really what happens is that's in lieu of a wage increase, which is one reason why American workers' wages have been semi-frozen for so long, particularly compared to inflation, because healthcare inflation is even higher than regular inflation. We'll talk more about that. Around that time after World War II, the fee-for-service system was sort of firmly entrenched, which is another major difference in our healthcare system from other industrialized nations. And what it assured is that profits and market forces would be the primary drivers of our healthcare system, not, as is true in most other industrialized countries, the best healthcare for the people of the country and the public health of the country. So I often think, and this gets to what do I think the toothpaste is in our Rube Goldberg health care picture. I often think that if an anthropologist came to this planet from another planet and they looked at the US healthcare system and they studied what is the purpose of this system, they would conclude that its primary purpose is to create reimbursable events. So it's not toothpaste, it's to create reimbursable events. Now, I know that's controversial amongst some folks, but I can't come to any other conclusion. 1965 was huge because Medicare and Medicaid came out, which was the first time segments of our population were literally carved out. And that was a game changer in terms of their treatment for healthcare and healthcare finances. As part of the log rolling and you slap my back, I'll slap yours of the Medicare compromise, it became illegal and is illegal to this day for the largest purchaser of drugs in the world, the United States government, to negotiate drug prices. So that was reaffirmed by the Medicare Modernization Act, and several times it's been reaffirmed. But think about that. Since 1965, it's been illegal for the largest purchaser of drugs in the world to negotiate what they pay. So even to this day, our trade name drugs cost 3.5 to 4 times more what the same drugs cost in other industrialized countries. 1973 was real interesting. So it surprises a lot of people that it was Richard Nixon who signed the HMO Act, but the key sponsor was Kennedy, Edward. And that made $400 million available as subsidies for companies that could show by their structure that they had restructured themselves to become what were then called HMOs, which had a legalistic meaning. And 2/3 of the recipients of this money were for-profit entities that never did manage care. They only managed costs. My own group health, truly an HMO, did not apply for subsidy from the HMO Act because they felt that would compromise what they were trying to do, which is ironic. In the 1990s, the Clintons were unsuccessful, comprehensive reform. People know that. And then in 2010, the Affordable Care Act was passed, which is what we would now call reform. So when we use the word reform, if we think about, well, what's wrong? What needs to be reformed? Well, most experts would say that there were and are, you could take this slide off, Reed, really three primary areas that were deeply broken and still are broken that needed reform. One was access. What access means is having no insurance or having under insurance. People just can't get it. Many people die, not specifically from the disease that they have, but because they can't get access to care. Hundreds of thousands. And there were 50 million uninsured Americans prior to the Affordable Care Act. And now there's about 30 million. So it's decreased significantly, though there's still a lot of uninsured. The second area in need of reform was quality. You know, all comparators between industrialized countries show that the United States is not in the top quartile or 25% of things like how long we live, how many of our babies live to be one, you know, basic public health things. So we're not getting much for the cost, and the cost is the third area that needs to be reformed. We spend about 18% of our GDP, while other industrialized countries are in the 10 to 12% range. And by the way, those countries consider healthcare costs a rising crisis, and they're in the 10 to 12%, we're 18%. So while the ACA has led to decreased uninsured from, say, 50 to 30 million Americans, we have seen virtually no improvement in quality or cost. And we can talk more about the ACA if people have interest in that. But what I really like to do right now is talk a little bit about the history of our costs in healthcare, because you can't really talk about healthcare without, or single payer without talking about it. So the third slide will help us out. Bottom line is the healthcare costs have been inflating for 70 years, 2 to 2.5% more than standard inflation of the GDP. So while we can say that in 1960, about 5% of what we spent as a country was spent on healthcare. Now it's 18%, and by the way, it's 18% of a much higher number than it was in 1960. So healthcare, actually, Reed, show me again. This is a very high-tech drawing of my arms. This is inflation, about 2% of the GDP over 70 years. This is inflation of healthcare over 70 years. And that 2 to 2.5% difference every year for 70 years leads to dramatic differences, is clearly unsustainable. And whatever your favorite hobby horse is, whether you'd like to see more money spent on, I don't know, libraries or armies, you can't spend it when healthcare is taking more and more of every dollar spent. We now spend about $4 trillion a year. Think about that. Inhale that for a moment. Of that 4 trillion, repeated studies break it down, and I'm not going to go into it today, but at various times in my career, I've created pie charts like this. We'll go, you know, where does the 4 trillion go? And it's knowable, you know, where does it go? But I want to talk about the parts of it that just make no sense to me. First of all, administrative overhead. That startles people. That's felt to be between 20 and 25% of $4 trillion. A lot of that is what would be called waste, but a whole lot of it is a testament to how complex our healthcare system is. About 10 years ago, I haven't updated the factoid, but I learned that about 18% of Americans who worked in healthcare. They were not doctors and nurses or lab techs or ultrasound techs. The vast majority of them were benefits coordinators, worked with administrating different insurance companies. So trillion a year. 25% of the 4 trillion is administrative overhead because of our complex system. The other thing that is very, very high consistently is our prices. For goods and services, our prices, there's two things to say about our prices. One is they're opaque. So a simple question like, what's my colonoscopy going to cost? First of all, there's going to be 20 different costs just from your payer or insurer or Medicare. And then it's going to have 100 different costs all over the country. And they might be different Tuesday than Monday. So they're totally opaque. Besides being totally opaque, they're higher consistently than anywhere else in the world. It is also appalling to me, and I don't say that lightly, that doctors, you're a doctor, but the way our system is set up, gets paid 2 to 3 times more for every minute spent cutting or invading than every minute spent coordinating, communicating, and thinking. That's just how the system was set up. When Reed contacted me about if I'd be interested in this talk, I'm going to read you directly what he said. Group Health moved to Paulsbo and became Kaiser Permanente. Doctors Clinic quit Bainbridge Island, and Associated Physicians moved to Swedish, which has now announced plans to close. Harrison built a clinic that they then decided to fold into Virginia Mason, and now Virginia Mason is being merged with CHI and Franciscan. There are a couple concierge doctor practices on Bainbridge Island. What the hell is up? He said, what the heck is up with healthcare here? What are the moving parts? And would I be willing to talk about that? And I actually said, I'd rather not talk about that. I can, but what I can talk about that is dear to my heart is how these local phenomena that we are seeing and we are all living under are actually nothing more than the local manifestations that everywhere in the country is experiencing of national trends because of these kinds of numbers I've been throwing around and because of the trillions of dollars. Always remember that if $4 trillion is spent, $4 trillion is there to be made, and there's lots of hands out. So what I said is the number one trend is basically related to people want a piece of the 4 trillion, or they want to maintain their piece, or they want a bigger piece. And that's basically how they approach that, is related to their understanding about how to optimize their revenue, decrease their costs, while paying attention to regulatory and legal requirements. That's rule number one. And if we go back to that toothpaste diagram of Rube Goldberg, our healthcare system was set up to create that kind of thinking. It made profit motive the issue. So someone smart said, if you don't like the outcome, look at a system, because every system is perfectly designed to create exactly the results that it creates. So our healthcare system is exactly designed to be really high cost, really average quality, and have an access problem. And these companies aren't breaking the law by thinking about how to optimize their revenue and decrease costs. They're living by the rules of the game. You don't like the rules of the game, change the rules of the game. Other important national trends, all organizations in healthcare, whatever, whether they're people who are taking care of patients, whether they're insurance companies, whether they're pharmaceutical trades, are trying to get bigger because they're imagining as that will enhance their revenue and market share and give them more leverage in the market. And they're right about that. A second big trend is the rise of consumerism amongst patients. For whatever reason, around the 1950s, when informed consent doctrine first became a legal entity, and things started to change a little, and Americans, this is said without judgment, began to see healthcare as a consumer good, any other consumer good. And some people would argue that their relationship, with their clinicians was replaced by legalistic protections. Is that a good trade or a bad trade? I don't know, but people existing in healthcare have to pay attention now to this consumerism amongst patients and purchasers of care. And then the third trend is the needs and increasing market clout of purchasers. So there's 5 enormoid insurance companies, 5, that care for something like 160, 170 million insured Americans. So these people are richer than, God, and they make some rules. They purchase care. So do employers. So what are we seeing? We're seeing mergers, acquisitions, consolidations all over the country. We see way less docs in independent practice, way more docs working for hospitals and other entities, but primarily hospitals. We see most of the big players, no matter hospitals, medical groups, insurers, device makers, pharmaceutical companies, struggling and trying to get bigger. And here's the thing. There is exactly 0 evidence that any of these trends are bringing down costs or increasing quality. Here we sit, and I think that's a good time to open up for questions. I'm tired of talking. Let's talk.
Well, thank you very much. That's an absolutely wonderful overview of the desperate situation. I just have a question, since you've been watching this for a little while, and then I'll get to you, Judy. Since you've been watching this for a while and supportive of different approaches, you talked to me about the value of single payer as eliminating a lot of being a new system that might have different results. Has the political or professional climate changed significantly since, say, the Clinton era, when a major reform was tried?
Yes, actually, it has. Most physicians support some form of single payer. Let's just say that. That's well known by many, many studies. And single payer should not be thought as a single entity. There's many versions of single payers that have different strengths and weaknesses, but most physicians favor that. And actually, the AMA forever was a major opposition to all efforts at healthcare reform for the last 100 years. And by the way, the AMA has never represented half or more of American doctors. Right now, they're about 18 to 20% of doctors, but most physicians favor it. In terms of politics, that's the hard one. Things get polarized in America. And the discussions about healthcare and Obama's, I think, really well-intended, hi, Alan Redland, that's my brother-in-law, and the well-intended idea that we would have community discourse about healthcare and that would inform it. It just wasn't going to work in this polarized setting. Like I said, because there's 4 million reasons, $4 million being spent on healthcare, why people want to hold their positions and can spend cajillions on public relations campaigns to convince Judy Morgan and Sheila Kerwin that single payer is socialized medicine. So it becomes not a discussion about fact, but a discussion like a lot of the polarization. So even in the Democratic Party, you have people saying, well, single payer will never happen. And that may be true, but the only thing missing for single payer to happen is political will. That's also the only thing missing to reasonable solutions to climate change, by the way, political will. But in America, a lot of things happened that were never going to happen. Women weren't going to get the right to vote. Blacks weren't going to get the right to vote. We weren't going to get rid of slavery. We weren't going to have a black president. I mean, it's about the people's will and how effective they are in turning it on. And I'm not here to be a commercial for single payer. That's not what I'm doing.
No, but you did say that about the process and the idea that it has to change, and that there are 4 million or trillion reasons why it won't change. So I just wondered if there were a few more than there used to be, why it would. And one of the things you said about doctors being uniformly in favor of a new system gives a coalition on both sides of the equation, if you will, to maybe look at change.
Yeah.
Judy, you had a question. Can you unmute yourself and go ahead and ask it?
Are you hearing me?
Yeah.
Okay. First of all, I'm going to really miss the Swedish clinic on Bainbridge and hope that Dr. Sarah Rice does something to help stay on there. But I'm really concerned about CHI Franciscan taking over our entire county for healthcare. I could list the terrible, terrible stories of people and their problems, health problems that they've received or gone through with Harrison Hospital. It's been terrible. And now we have CHI Franciscan, which apparently their Catholic control of birth and death is going to be controlling our choices in Kitsap County. There is a group that is absolutely trying to fight that and asking the Attorney General of Washington State to do something about it. But what is your view on it?
Of the acquisition or of the Catholic footprint in healthcare? Which are you asking me?
The Catholic footprint in our county, yeah.
Oh, it's in the country. It's in our county too. But this is interesting because and I've never worked for CHI. I've had relationships with CHI leaders in my role at Group Health. And what is known is that in the country, a little over 25% of all hospital beds are owned by Catholic organizations. In Washington State, it's more than that, actually. It's probably closer to 40%. And that has potential implications. This is what people worry about for women's reproductive rights and that sort of thing. And people worry about it. And actually, the Attorney General in this state, who has been asked to look into it, has been one of a few attorney generals in the country who said, we need to look at this because we need to make sure the services that our people need, they can get. So he's been kind of interested in this before this particular merger. I've seen situations where a merger has happened where the Catholic organization has set up the availability for women's reproductive services fairly easily accessible by the community, but not done by them.
Oh.
I've seen that happen and actually subsidize it. In other words, they think they'll make enough money that we can afford to have a birth control and termination clinic. Secondly, I want to say that in many, many years of working in lots of hospitals and with lots and lots of healthcare people, in general, and it's really hard to generalize, but the Catholic systems have a vision around care and around what they see as doing the work of Jesus that's way closer, even though I'm not a Catholic, to where I have been with healthcare around care and are giving people what they deserve. They're less likely to get, this is my opinion, blocked by the profit motive. Say that several non-Catholic healthcare hospital systems in the country, like HCA, which has like two of the largest fraud settlements in American business history, for-profit, non-Catholic, and it's all about ka-ching, ka-ching, ka-ching. So I think there's a lot of good to be said for the vision around the patient and service in the Catholic systems. And what I would do when I was at Group Health, and it's like, we can't even work with you, Catholic system, because we worked with several in the state, unless you help us in providing access for women for the care they want and deserve. Whether or not you provide it, that's less important to me, whether they are doing it. That's my opinion.
Well, I also want to ask if doctors are getting better with palliative care for people who are dying.
Yeah.
And instead of trying to give them an operation and give them more drugs, when people stop wanting to eat, letting them not eat. I've heard stories lately of people not being forced to eat, but being encouraged to the point where they continue on when really they have no quality of life.
Yeah. I think doctors and systems, healthcare systems are getting better, but doctors are individuals. It's interesting that some of the finest and most compassionate and empathic doctors and nurses I've ever met in my life have worked in oncology and hospice, of course. And the doctors, not so much the nurses, and I've experienced this with both my parents before they died too. Some of those docs in oncology have trouble giving up.
Yeah.
Some in every specialty have trouble giving up because you're trained to, find it, fix it, find it, fix it, find it, fix it. But the systems are getting better and better. And I'm calling them systems of care because I don't know what healthcare all of you have, but one of you, I think it was you, Judy, you hope that your doc,
Yeah.
you think very highly of your doc, which is wonderful. And I hope every one of you does. But the fact is that until you have systems of care making the right thing to do, the easy thing to do, you're each stuck with individual heroic actions, hoping you have a wonderful doctor, you have a wonderful doctor, you have a wonderful doctor. And if you don't, sorry. Systems of care, good systems of care are the answer to that, where, you're not going to slip between the cracks. And the systems of care are putting in very good, hospice and palliative care services and systems. And the nursing profession gets an enormous pat on the back from me for their sometimes helping pulling the doctors along. Come on, gotta let them die.
So there are those alternatives. I think also about the paucity of gerontologists in the field, because it's all about those consultations and conversations and communications that, as you said earlier, are not reimbursable, or at least not at the same level as an invasion or a stent or any of the feeding tube things that Judy was recommending or commenting about, rather.
Yeah.
There are some movements. I know prominently Atul Gawande has made a little attention with his interest in the errors of trying to keep people alive against all reason. So there are some movements in the medical profession that are kind of countercultural, if you will, to the reimbursable expenses.
Yeah, I could have said, and I'll say now, I made a deal about consumerism in patients and purchasers of care, meaning I want to have my healthcare be just if I go to the art store and I want this paintbrush and that paint and that paper. Well, I want, one MRI on my brain and one this and one that. And that's well and good, but it's not the relationship. And I also should have said that a positive side of that rise of consumerism in patients is them saying, I want to die when I want to die. I want you to talk to me about the alternatives for taking care of my lung cancer, the risks and benefits of different approaches, and then I'll make the decision based on my values. This is putting the patient at the center of their healthcare experience, not Dr. Welby. And there's a lot of that going on. And in fact, you probably know that our state was one of the first to actually enact legislation to enable patients who had to jump through some legalistic hoops to end their lives. I'm proud of that. The first patient of the state was group health.
And we have our community resource navigator, and we have has invited people from the End of Life Washington to talk to this group, and those videos are available. That video is available, and we have that information if you have more questions about that. Jim Hayner has a question. You're still muted, so you need to push the little microphone button at the bottom. There you
I'm
go.
sorry that I didn't understand that. I appreciate the time, and I appreciate what you just said. And as a matter of fact, I'm going through right now a perfect description of what you have just mentioned in healthcare. I'm in hospice at this point, and have had a team of about 5 committed, dedicated docs from Virginia Mason who always allowed me to make my own decisions and provided all of the information that I needed to determine what was the best direction to go. And my whole issue here is quality of life. And once I've exhausted, like as over a 6-year period have, all the opportunities, they could have gone on if they'd wanted to experimental medications and so forth that would really destroy potentially the quality of life that Catherine and I have are enjoying right now. So I too worried about the takeover at the hospital, but it was all arranged. I mean, I have based on the conversations that we'd had here at the senior center that Reed had talked about. I have it all set up so that in the event that I want to use the death with dignity process, I can do that. But I have to tell you that palliative care and hospice has been phenomenal in helping me make decisions about where I want to be with my life. And you're right on. You're right on. I worked also in the healthcare industry for many years, and so I understand the profit part of the thing. So I appreciate what you had to say and what you were having to say, and look forward to hearing more.
Thank you, Jim. I really appreciate your having the courage to tell your story. Both my parents died under the care of hospice, and my dad, who had very late prostate cancer that actually should have never been even diagnosed because he was in his 80s when it was diagnosed, which there's not much you can do good. But he got in a system of well-intended docs, not in a system of care, who literally and well-intended believed they could just save him by just doing one more invasive thing and one more invasive thing and one more invasive thing. And none of the studies supported what they were doing. And what the eye-opener for me was these weren't actually bad people, and they weren't even people who just needed more money. They were good people who had almost tricked themselves into thinking, if I just do this one more thing. And it was because they hadn't embraced the other side. How is death part of being a healer, and how do I deal with that? Thank you.
Yes, thank you, Jim. I want to go to the question about the consolidation and the challenges, and what sort of world somebody that's a doctor working out of the Swedish clinic, or what their options are. You said that a lot more docs are going to work in hospitals, and that primary care is pretty much a vanishing thing for small clinics.
No, independent practice is a vanishing thing.
So, yeah, excuse me. What are the pressures on docs, and what kind of options do they have right now as the world is turning underneath them?
Okay. 400 medical students and residents in America commit suicide every year. This is before they've even gotten into practice. Alcoholism, drug abuse, suicide, and divorce have for decades been very high in docs, and it's actually getting worse. Docs in general in America are paid very well. Even the primary care docs, and estimates show that if you choose to go into primary care instead of cardiology, you're agreeing to leave $5 million on the table over your lifetime earnings. And, you know, you might vary from an average income of an orthopedic surgeon, you know, $600,000, $700,000, $800,000 a year. Psychiatrist, internist, pediatrician, family care doc, 200 to 240 for huge hours. And if you ask the people on the lower end, which included me, are you paid enough? For the most part, the answer is yeah. Other people are paid too much. And American physicians are paid more than at any other time in American history and more than any other place in the world. But there is this broad range dependent on cutting and invading versus thinking, communicating, and you know, coordinating. So the salary isn't really the issue. For a lot of American docs are dissatisfied. A lot of them say, I wouldn't go into it again. I wouldn't encourage my kids to go into it. Their burnout is rampant. And it's not just in primary care, it's in everything that's been looked at. And it's about loss of control, and it's about enormous regulation. So it's a very regulated industry in one way, but in other ways, it's, you know, it's not regulated. So docs, if you add to what I just said, the financial fear of going under if you're a small group. Remember, you now have to have an enormous amount of your staff dedicated to dealing with 18 different insurance companies and this stuff that wasn't why you went into this. It's become, about 5 years ago, for the first time in history, more American doctors worked for hospital systems than were in independent practice. First time ever, about 5 years ago. And now other things too, working for pharmaceutical entities. We're seeing the concierge medicine movement on Bainbridge Island, which has its own factors leading to it. Doctors have been struggling, I would say emotionally, more than other ways. And the way it's been acting is retiring earlier, fleeing from small groups into hospital systems, and sometimes going back for another residency, depression, suicide, divorce. You know, does that answer your question?
Well, yes, but so that's I mean, obviously they're hitting the wall. There aren't a lot of options. For the majority of physicians, I'm thinking they're not going into this line of work necessarily for the profit motive, but they do obviously want to be compensated for the enormous amount of time and energy that it takes to be a good doc.
Right.
Is there an option where that they would be supportive of, that we as their patients would also be supportive of?
Yeah. And it's not universal. And I'll say this, you know, I've managed 1,200 docs at Group Health. I've encountered and gotten to know thousands and thousands of docs in my lifetime. I don't think my people docs are some exalted status, but for the most part, they're good people, and they didn't go into it to get rich. Some of them had blocked personalities from the 5th grade. I'll grant you that, but they didn't go into medicine. You don't go into medicine to get rich. You get an MBA or go into venture capitalist types things. Most of them went into medicine for some version. I want to do good. And there are systems of care and things one can do that are harder to find, that insulate you a little bit from, or somewhat from, the business of medicine. And there, you know, for example, my own Group Health was purchased by Kaiser Permanente. Well, Kaiser and Group Health were both founded in the 1940s. They were HMOs who both didn't want handouts from the HMO Act because they were real HMOs, not for-profit HMOs. And, you know, when you worked at Group Health for a long time, you weren't thinking about money or the profit motive much. You were protected by that, and you had a salary. So I was never going to order something on you because I'm behind on my divorce payments. And some of that has stayed. Some of it, the marketplace realities have forced some of those things to change a little bit. But Kaiser Permanente is the largest, prepaid healthcare organization in the country now, and it's having no trouble, hiring docs and retaining docs who get a salary, who are somewhat insulated from being deeply involved in the business of medicine as individuals. But there's a price for that. They lose some autonomy. They work for a system. They're being measured on everything. How many patients a day do you see? What your quality scores, how your patient satisfaction scores, on and measured to an extent that is invasive to some of them.
Okay, so how would that that kind of classic HMO, the nonprofit HMO, compare to a vision of a national policy on healthcare that would be, in other words, is that what it might look like? It would be more like an HMO than our current world if we were a customer of single payer, some form of single payer healthcare.
Yeah. Actually, that's a good analogy, Reed. I think that if you look at the various single payer systems in the world, there are many types, right? There's the type where the government there's no insurance companies. The government is the kind of insurance company. They start off saying, look, we have this many dollars to spend on healthcare in 2021 in this country. We're going to put it in some budgets. We don't have more than that. And so we're going to have to prioritize certain things, which people who want to find fault call that rationing. And I say, come on, we ration all the time. We ration by whether you have money to pay for X, Y, or Z, whether you can afford your copay, whether, we just do it a little less honestly, which means we don't have the societal discussions to guide us. And they'd say, we have this much money and we're going to spend it. Now they can either own the delivery system too, or it can be an entirely private delivery system that is owned by doctors, nurses, whoever owns the delivery of care, who contracts with the payer, which would be the government. And then there are some countries that you can even have full-on capitalism with universal health care. So Germany, for example, this is how many uninsured Germans there are, 0. And they have a bunch of insurance companies. And of interest is those insurance companies are not allowed to compete on cost. They're only allowed to compete on quality and service. So it can happen a lot of different ways. But what would happen is, if we had a single payer, you'd say, look, here's the list of unified benefits that people can expect to get. If they want more than that, fine, but they're going to have to pay for it. And then that list of benefits is one list of benefits. Right now we have 50, one set for each state, and then another hundreds and hundreds of different insurance companies and how they mandate it, which leads to all the people that need to work and benefits coordinators and things like that, and the complexity. So you'd say, here's our list. Here's how we're paying. The choice, which is in America really huge, is bigger, as you can imagine, with a single payer, because you can choose anybody. You could choose your doctor in Minneapolis. They don't even have to be in Seattle or Kitsap. Go anywhere you want. People don't talk too much about the choice is by far the broadest in a single payer, because it includes all purchasers of care. All providers of care. Right now, the 25% administrative is about, coincidentally, is about the same number that insurance companies right now spend on something other than care. It's around 25%, right? That includes their profit, their management, their bureaucrats, their advertising, all that. Medicare, it's about 5%. that is not spent on care. So, and this is a big difference that I'll just briefly state between public option, let's put in a public option as Biden has talked about, and let's have a single payer. And that big difference is that if you have a public option, you haven't actually decreased the complexity or the need for cajillions of benefit coordinators and different lists. You've just added another system to the existing kind of crazy, out of control quilt work. Whereas if you have single payer, oh, now you mean we don't need 8 billion insurance companies and all the people that exist to do their work? No, we don't need them. So your choice would be fuller. You would have clarity and transparency about what's available to you and what it would cost. And the total costs go down. But it's complicated. You might see that your wages go up because less is being garnered for your health care through your employer. Next question.
You know,
Eleanor.
if I can, if you don't mind my interjection here, do you have any idea? I'm sure you do, Michael. How many hours the average doc spends at no cost whatsoever, no reported cost, on just doing paperwork?
Yeah, probably 20-25% of, I don't know it in hours, but and hours vary by specialty, but it's 20-25% of their time is with administrative tasks.
Sure, and you can't believe the amount of hours these guys spend, you guys spend, just keeping up with the records management systems that we go today. So you're absolutely right. My daughter lives in Spain and is in the healthcare system there, which is single payer, and it's very, very effective, very positive. I have teenage grandchildren who have two of which have gone through COVID and are just fine now, and their approach to the care was really very, very good. So I've experienced both single payer and, of course, the bureaucracy that we're involved in right now. And thank you again for this.
So Eleanor had a question.
Thanks, Jim.
Eleanor, you need to unmute yourself.
How do you?
Am I on now?
Yes, you are.
Okay. My screen was telling me 4 different things at once.
Well, you're a flavor of the healthcare industry.
Yeah,
There you
exactly
go.
right. I mean, it seemed perfectly logical to me. I'm getting used to it. I just wondered if you thought that the concierge system of smaller practices was a reasonable alternative to the, CHI Franciscan model of we will all have to go to the hospital for our care.
Yeah. Let me just back up and talk a little bit about the concierge movement in general. And by the way, I have a daughter who's 37, who's a physician, and she's in primary care. So I, beyond myself and whatever jobs I've had, have seen through the lens of a younger doc. The concierge movement was started by actually someone I went to high school with by pure coincidence. Maybe I want to say now 10, 12 years ago, 15 years ago. And the concept was, look, if I remove myself from the regular system of care, if I'm a primary care doc, I might have 1,500 or 2,000 people in my panel, right? And I just say, you know what, I'm just going to take care of, put in your number, 150, 200, 400, 500, a much smaller number. I'm going to charge them a monthly retainer, and I'm going to be kind of at their beck and call for their care needs and to help them. And it varies, for some of them, it's like if you're in Florida on vacation, and you get sick, I will fly to Florida and be your translator in the hospital. A lot of them don't do that. And the idea was, look, this is going to work for the doctor because they'll be able to practice, they'll be given the time they need, and they're going to be less beholden to enormous amounts of administrative paperwork because I'm only going to take cash. We're never going to have a conversation about the 30 different insurance companies. And for the patient, it's going to work because, you know, Eleanor is going to be happy because she's not rushed through like she's in a grocery store line to pay, hurry up, get through, you only get 3 minutes today. And she's going to recognize that care is good. That was basically the belief system behind it. However, then it gets complicated. Right now, we have a huge primary care shortage. Say this state, I think there's 31 counties roughly in Washington state. I may be wrong by 1 or 2. And 27 of them are primary care shortage counties. So now you're going to take some of these fine primary care docs, you're going to take them out of the system. For good reasons, they want a better lifestyle. And you're going to say to certain patients who are, for good reason, if you can afford it, more rationing, you can see Dr. whoever and all it's going to be is this much a month, and they will take care of you and look after your best interests. And now you've created an interesting perverse incentive where you're hurting the actual system to create certain patients who can afford it get better care, and certain doctors who make the change can have a better lifestyle. So this has added complexity, and I would argue that what they are providing for you in that concierge service is what I provided forever at Group Health, because I was part of a system of care. It was less involved with my individual heroic actions, and rather we had a system to hold you, care for you, look for your prevention needs. So I totally understand any doc who says, I've had it with this system. I'm going to go into concierge medicine because I'm going crazy and I'm tired of not seeing my kids and tired of having a call if I can get an MRI on Judy's brain because I'm worried she has a tumor. I'm going to take care of myself. And I don't blame Judy or Eleanor for saying, you know what, I'm tired of this runaround and I want a doc who I trust, who's going to be there for me. And I thoroughly understand that. And part of me goes, gulp, isn't this kind of what we were supposed to be doing anyway, guys? And what good systems of care do? So that's my complex answer to that.
I think we're running out of time, but Tom, can you unmute yourself? You had asked, you wanted to have a question. I muted you because your phone was ringing, but you'll have to press the unmute button if you can find that. And then you can ask your question. And I think that will be the last one. Go ahead.
Am I on now?
You are.
Yeah, okay, great. Listen, as a person who's thoroughly familiar with the practice of medicine in Germany, my wife at 14 years old worked for the 6 firms that actually, there isn't a one-payer deal in Germany. There are really 6 separate organizations that compete somewhat with each other, but not totally, right? Mm-hmm. But there's such a massive confusion about what is going on in Germany, how superior the system is. I had a house for 40 years. I know what it's like. When you make an appointment for a doctor in Germany, they don't tell you what time to come. They tell you to come Monday morning. You go there Monday morning and there's 45 people waiting there, and you sit there all morning long for your appointments, right? Mm-hmm. And that's how wonderful the system is. My son plays in the symphony orchestra there for 20 years, knows fully well about what the problems are. I have cancer, I have a heart condition, I'm 86. You're gonna close down the place in Bainbridge Island, and I'm going to walk to the clinics, which I still do, walk up to Swedish, walk up to Virginia Mason. One of these days, I'm gonna drop dead on one of these streets going back and forth. I love the hospital on Bainbridge Island, right? I think it's far superior to the German system, and I've been through it all, right? And I have multiple conditions. We give up this little place on Bainbridge Island, we're giving up a tremendous asset to guys like me. My wife doesn't drive, I don't drive. You're gonna take the ferry to Bainbridge Island, you're shooting 8 hours and $100, $150 if you go to have a beer between the ferry fees, parking fees, this and that. I went there for my first shot. I waited online for 2.5 hours. I'm 86 with a heart condition, cancer, and 14 other miscellaneous problems, but I can still walk up Cherry Street in 23 minutes and get to the Swedish. How long is it going to continue? In other words, I'm getting frightened because we're not going to have a facility for a guy like me. And there's a whole lot of people like me who don't want to see this place leave Bainbridge Island. I'm willing to support it financially if they stay there in some degree. Can't we work out something, Doc? I mean, you're an expert on this. Is it so hopeless? It might well be hopeless, right?
No, it's not hopeless. Couple of thoughts. First of all,
that Dr. Nelson said, would you be willing to pay more? Yes.
Yeah.
You know.
Okay. Now we're going to let him. Now we're going to let him answer, Tom. But thank you for that excellent question.
Yeah, I can go on for an hour and a half, but that's another story. You know that already.
Okay.
Yeah, go ahead.
A couple of thoughts. First of all, I'm not a defender of the German system in particular. I'm just saying there are forms all over the world, and every healthcare system has problems. There is no nirvana system. You're basically, what problems do you choose to have, and how do you solve them? That's the question. Now, in terms of, I really appreciated your very well formulated. You really drew a great picture for me of what it's like if you have to go to Seattle or this or that, the other. And what I can tell you is systems of care listen to patients. So when I was with Group Health, the people around SQUIM, really wanted us to set up a system of care for them. And they would put together, like 30, 40 people in a meeting and invite a couple of us out, and we'd hear from them and we'd talk to them. And they're trying to make their case for why a system of care should be there for them. And I'm saying you do have power, particularly in numbers, and you speak up. And whether it's the Swedish system and you want them to stay here, got it. Healthcare economics are very complex, and you're making undoubtedly an economic decision to do this. And we want you to talk to us about other options and what they might look like and how we might contribute to them. You go into it with a sense that you are actually the ones paying the bill and you have a voice. So use your voice. It's not easy, but it's not hopeless, Thomas.
Okay. Boy, this has been a very informative, I know I've learned a whole heck of a lot, and useful time with you. I will say that I did come across the Physicians for a National Health Program, pnhp.org, which might be useful for people to explore. And we will look at ways that we can continue this conversation. And I'm sure, Dr. Soman, if you have some suggestions for me as a next step, I would welcome that.